Right.
Welcome to Inside Healthcare on ReachMD XM 157, the channel for medical professionals. I'm Bruce Japson, the healthcare reporter for the Chicago Tribune, and with me today is Tim Dugan, co-founder of Water Street Healthcare Partners, one of the largest private equity firms in the United States that's focused solely on the healthcare industry. Established in 2005, Water Street has become known for its healthcare expertise, investing in several different businesses through acquisitions and strategic partnerships with some of the biggest medical product companies in the nation, like Medtronic Inc. and Stryker Corporation. Prior to founding Water Street, Mr. Dugan was a founding partner at One Equity Partners, who you may be more familiar with because it was the $5.5 billion private equity arm of J.P. Morgan Chase. Mr. Dugan has a bachelor's degree in electrical engineering and economics from Stanford University and a master's degree in business administration from the University of Chicago School of Business. Tim Dugan, welcome to ReachMD.
Thank you, Bruce, and thank you for having me.
Well, this is a very exciting area. I, as the healthcare reporter at the Tribune, I write a lot about diagnostics, and there is some real innovation going on in this area. And what you're going to tell us about is about this trend in point-of-care diagnostics. And if you could just give us a little 411 in layman's terms, what exactly is point-of-care diagnostics, and how did private equity get involved?
Sure, I'll give you a simple example that I think all of your listeners will be familiar with and will remember the experience likely all too well. But imagine a primary care setting where a number of years ago a patient comes into the office complaining of a sore throat. It looks like it could be strep, and you run a throat culture and have to tell the patient it will take a couple of days to get the results from the lab, and the patient complains about not getting treated. They feel bad and they want to feel better and begin asking if there isn't something that could be done now. Couldn't an antibiotic be prescribed or something like that? And in that example, patient satisfaction is generally low, and or the practitioner is put in the difficult position of potentially prescribing an unnecessary antibiotic to that patient in order to satisfy them. Those were the old days, of course, and today, when a patient comes into the office complaining of a sore throat, you can do a rapid strep test right in the office, and in a matter of minutes, the test will reveal if the patient has strep, and if so, proper treatment can be prescribed to the patient. Great example in this case where the patient is delighted, they have a clear diagnosis, hopefully will feel better very quickly, and as the practitioner, the doctor, is delighted because they were able to quickly and effectively treat the patient. And again, this is one small example of a growing trend in medicine where you're bringing these tests out of the central laboratory and bringing them into the doctor's office, into the hospital at the patient bedside, and can provide immediate results to the patient.
You probably answered my question already, but this seems to be an area that would be less expensive and less of a headache and less time-consuming for the patient and the physician as well.
I think you're exactly right, and it's one of the reasons why we think it's an attractive area for investment. It absolutely saves time and money in the long term because the test can provide immediate results. Doctors are able to treat patients faster than ever. Once they receive the results, they can immediately determine the appropriate next steps and communicate them to the patients. You avoid the time and cost of having another company involved and having to transport that sample to a lab and wait for the results. It provides better patient outcomes. Again, for some of the same reasons, doctors can receive results and recommend treatment patients quickly. Satisfaction levels go up, which is very important to hospitals and individual practitioners alike. And additionally, it's an additional stream of revenue for the physician or the hospital where they can provide this test on site. And again, if you go back to some fundamental tenets here where if you have a product that improves patient outcomes, that lowers aggregate cost to the healthcare systems and is a good business opportunity for the practitioner, you have a product that's very appealing. And I think many of the point-of-care diagnostics tests fall into that category.
Well, if you're just joining us, you're listening to ReachMD on XM 157, the channel for medical professionals. I'm Bruce Japsen of the Chicago Tribune, and join me today is Tim Dugan. He is the co-founder of Water Street Healthcare Partners, which is one of the nation's largest private equity firms focused solely on the healthcare industry and investing in the healthcare industry. And we're talking about point-of-care diagnostics, which will be coming to a physician's and patient's bedside near you. And Tim, if you will, could you give us a lay of the land out there of who is into this, perhaps as far as I know that your firm is, but could you give us a little of what's going on with point-of-care diagnostics and kind of what's out there that physicians and patients might be running into?
Sure. I think the most common point-of-care testing in doctors' offices, particularly in the larger practices today, are routine chemistry tests. Today, doctors can draw a small amount of blood from the patient and get immediate results on items such as the patient's level of lipids, cholesterol, glucose, liver enzymes, and these results will enable them to immediately assess if the patient is at risk for conditions such as heart disease, liver disease, or diabetes. for patients who have already been diagnosed with these conditions, it provides an invaluable tool for the doctor to help monitor and manage chronic diseases in particular. So that's an area where we see continued opportunity, and we think that panel of tests provided at the patient bedside will continue to grow. Many doctors today also offer point-of-care testing for infectious diseases, with the most popular ones being for strep throat, which I mentioned in the example earlier, and the flu. And what's fascinating here is that the new point-of-care tests that are being developed for other serious diseases, for example, with an oral fluid, not even having to draw blood, doctors in about 20 minutes today can do an HIV test in the doctor's office. And there are many benefits, again, with the patient for that particular disease and having very rapid diagnosis. You're going to see, I think, some upcoming developments in the areas like cancer testing, where, for example, Beckman Coulter and others have made improvements to tests like the fecal occult blood test, which is a great screen for colon cancer. And the underlying technologies in that test have shifted to improve the accuracy of the test. You also have developments in molecular technology and screening for more complex diseases and cancers that are coming through the development pipeline and will be offered soon.
Well, Tim, could you tell us a little bit about also the reimbursement incentives for point-of-care diagnostics? You had mentioned earlier about the potential for the physician to benefit from this trend, but could you give us some specifics? I mean, you constantly, doctors know and others know that Medicare is squeezing physicians on the outpatient reimbursement front, but are there some reimbursements either in the private insurance sector or Medicare or Medicaid for point-of-care diagnostics?
There are, and they're increasing. I would say, to oversimplify, to the extent that the point-of-care diagnostic test provides a comparable outcome to the central lab test, it is becoming increasingly straightforward to get reimbursement for those tests at similar rates. And again, importantly, for the physician, that creates a revenue opportunity for the physician where they can be reimbursed for conducting that test as opposed to the central lab.
And is it more on the outpatient side?
It's both outpatient and inpatient, where in a critical care or in an emergency room setting, the need for stat tests is obviously high, and point-of-care diagnostic tests, as a matter of convenience and in providing timely information to clinicians in that environment, is very, very useful. In a more traditional, non-intensive care setting in a hospital, you can use the hospital stat lab or indeed even a central lab to conduct many of those tests. And then outside of the hospital, in individual practitioner's office setting, again, a lot of tests, whether it's in women's health or in family practice, are being moved into the doctor's office, creating both better patient outcomes and a great business opportunity for that physician.
Now, would these point-of-care diagnostics, would they tend to be more toward the primary care physician, the family physician, and the internist? Would they be seeing more of these than the specialists, or is there a certain area where this is going?
I think it's going to run the gamut. I think you have things like routine chemistry tests and infectious disease tests that are great for the family practitioner and the primary caregiver. You have other tests, molecular tests, and cardiac immunoassay systems that will certainly be used by specialists. But I think one of the interesting trends here is that as these tests become more simplified and as they become less expensive, you do have the opportunity for the primary care physician to conduct a number of these tests in their offices as opposed to having to send a patient to a specialist. You can do some initial screening in the primary care setting. Again, better patient outcome, better opportunity for that primary care physician to determine what is the appropriate next step for that particular patient.
And in effect, right then and there, you could be saving some money on not having to refer someone into the hospital or to a more expensive, more specialized setting. Have there been any studies done, or if you could give us an example of how less expensive something would be? I suppose if you're avoiding a inpatient stay, certainly you're going to save money there, but just on the, sort of the buying front for a consumer or a health plan.
Yeah, the tests and the actual cost of the underlying test initially are very comparable to what you'd find in a central lab setting. So there's not necessarily cost savings attached to that immediately. However, as that test gains traction in the marketplace and the frequency of use goes up, the manufacturer of those tests are able to bring their costs down and actually provide a savings. But the bigger savings really are at the system-wide level. So to the point you made earlier, if a primary care physician can provide an immediate result to a patient, they can likely avoid having to bring that patient back for a second visit. They can potentially avoid having to send that patient on to a specialist when they can determine in their office at that time if that particular visit is necessary or not. If they can get a rapid result on a test, they may prevent a particular issue or disease with a patient from escalating to the point that you actually have a requirement for hospital inpatient stay for that particular patient. So there are many ways when you look at it at the system level where you're improving the efficiency of the delivery of care, you're bringing more rapid diagnostic and therefore treatment to the patient. You may be bringing better management, as I mentioned earlier, of chronic diseases to the patient, therefore eliminating those events that require the patient to come back and see a physician or check into a hospital. All of those items really drop costs overall in the system. And I think the payers, particularly at the government level, they recognize the benefits of these kinds of cost-saving initiatives and are supportive of more tests moving toward the patient bedside.
Well, I would like to thank Tim Dugan, who has been our guest. He is the co-founder of Water Street Healthcare Partners. He joined us from his offices in Chicago, where Water Street is one of the nation's largest private equity firms investing solely in the healthcare industry. And we've been discussing point-of-care diagnostics, which will be, if you are a consumer or physician listening in, coming to a bedside near you. I'm Bruce Japson of the Chicago Tribune, and you've been listening to Inside Healthcare on ReachMD XM 157, the channel for medical professionals. We welcome your comments and questions through our website at reachmd.com, which now features our entire medical show library in on-demand podcasts. And I would like to thank you today for listening.
Good evening, colleagues and senior colleagues. You are welcome to today's meeting. And before we start, we want to set some ground rules. We want all of us to mute as the presentation starts. We also want all of us to put off our cameras as the presentation is going on. Let's be aware that we are in a public space, and don't leave your phone with your children or your devices with your children. You may expose your private affair on the platform. So kindly take note and be very particular with your devices you are using. On this note, we want to say a big thank you to all of you for your participation in this program. This is a program set up by the National Executive Council to ensure that all of us get to learn and also have CPDs to renew our pins. So we say a big thank you to the National Executive Council led by our president, Dr. Abudu Ahamani. Without much ado, I'll hand over to our presenters for today. Our presenter for today is an astute medical laboratory scientist and a clinical microbiologist. She works with the Kolebu Teaching Hospital as a client service manager and a microbiologist. She has an MPhil in medical microbiology from KNUST and a Doctor of Medical Laboratory Science degree from the University for Development Studies. She's currently pursuing her PhD in medical microbiology at the University of Ghana. I welcome Dr. Esther Okain to lead the presentation. And let's still remember that the ground rules still holds. Let's mute ourselves. Let's put off our cameras. Let's take care not to expose our private issues on the platform. Thank you. Dr. Okain, over to you.
Hello, good evening, Dr. Kwashi.
Okay, good evening. I think we are set for you to do your presentation.
Okay. Thank you very much, and a good evening to everyone. I want to once again thank the executive of Gamls for seeing it right to call me to do this presentation. I'm very privileged. So I believe by the close of this session, like our General Secretary said, we will learn new things. We will unlearn some wrong things that we do, and we will relearn new things. So today we are talking about clinical microbiology setup, particularly the bacteriology lab. So by the end of this, we will establish the need for setting up bacteriology lab, and then we'll know how to plan to set up the lab. We will know the requirements we need for the lab, and then the cost involved in setting up the lab. All right. So what is the need? Why the need for a bacteriology lab in a hospital, in your hospital where you work? We have found that the bacteriology lab plays an important role in patient management and treatment. Secondly, there's a gap between practicing labs in the country and labs that run microbiology. Also, there's an abuse of antibiotics in Ghana and globally, leading to a rise in antimicrobial resistance. This is the need. This is the reason why we need to get a lab. So what is the role of the lab? What is the important role we say a microbiology lab plays that we need to open it and add to hematology and chemistry that we are running already? All right. So with respect to the patient, when you have a microbiology lab, bacteriology specifically, we can detect the presence of a pathogen that is causing an infection. We can also identify that particular pathogen, and then when necessary, you can get the appropriate antibiotics for the treatment. So at an institutional level for your hospital, the benefits of this lab in hospital is that it will help in antimicrobial stewardship. That is how to give out the drugs. It will help in detecting and controlling of hospital-acquired infections. Then on the community level, in conjunction with the public health units, bacteriology lab can help in disease outbreak. During the recent flooding, or even when there's an outbreak of cholera, you see how bacteriology labs are involved in identifying and establishing the presence of the outbreak. Also, when there's a new resistance in antibiotic drugs, it is the bacteriology lab that can help in identifying this. And we saw the data is reported to the community up to national so that we can prevent the spread of these infectious diseases. Now, the second is to look at the gap. So this is data collected as at 2023, looking at government-supported health facilities, that's CHIPS, healthcare centers, maternity homes, polyclinics across the country, government-supported, and about 6,885 facilities were found. Now, out of these facilities, how many of them are said to be running bacteriology? Woefully, 98. This is government supported, not health, not private. Woefully, 98 labs are said to be practicing true bacteriology. This was data collected last year, and the margin is 1.4. Now, coming to Greater Accra region alone, there were 1,530 hospitals, government-supported hospitals, and those that ran bacteriology were just 17. And then looking at, well, we will say that CHIPS do not have to run bacteriology. So let's come just to hospitals, polyclinics, and healthcare centers. In Accra, we had 291. And if 17 are running bacteriology, still, there is a big gap. There is a very big gap to be filled. So this led me to perform a short intern survey. I didn't get much responses though. This is about 55 interns. And these are their qualifications. Majority of them have BS Med Lab. A few had MLSD, MPhil, and then diploma in medical laboratory certificates. Now, I asked of their interest in the fields, various fields. Majority of them were hematology, of course, undisputably. And then followed by microbiology, and then we come to clinical. So you can see the interest is there. We have interns or people who have just been trained from our schools, and they have the interest in doing microbiology. But then the labs are few in the country. I went forward and asked them, which area will you want to work with when you are done? And surprisingly, maybe this data is skewed because I took it from Lekma Hospital and Kolebu Teaching Hospital, where microbiology is done extensively. So majority of them wanted to do microbiology. So there's the interest. We have students or we have trained personnel who have the interest, but then they end up in hospitals with no laboratory facilities. All right. So now we've established that's the gap. Let's look at the abuse of antibiotics. It will be interesting for me to say that all those in this first half of the year who have taken antibiotics without prescription should go to the reaction, the chat please, and click a smile. You'll be surprised the people who click a smile or a thumbs up that they have taken antibiotics without prescription, or they've given antibiotics to their children without prescription. So this was a study in 2012, seeking to find self-harm in tertiary students. Now, they found out that 70% of the tertiary students were doing self-medication. And the most common drug they were using was amoxicillin. And the most frequent time they would take, at least every month, you find someone taking antibiotic without prescription. This is very alarming. In 2021, 23, quite recent. Okay, so I dumped this. So 2021 in Abokobi, the same study was done looking at residents, and they found 36% of them taking antibiotics before, taking antibiotics without prescription. And they said that it was successful. The last time they had an infection and they took antibiotics without prescription, it was successful. That's 30% of them said that. So there's no need going to the hospital to go and see a doctor and go through. When I know that when I get this signs, I can just take this drug and I'm okay. And others also, 64 said that It is because it is easy to buy the drugs than going to sit in a queue, seeing the doctor, all those things. They will just walk. This is also quite alarming. And then very recent, last year, another study found 46% of self-medication among people who attended Medina Polyclinic. So it means that a lot of us, like I'm saying, if we are supposed to go to the reaction panel, comes up, majority of us this year would have taken antibiotics without prescription. Now, let's talk about antimicrobial resistance briefly. So you take drugs, antibiotics to kill a bacteria. Now, when the bacteria persists to grow in the presence of the drug that is supposed to kill or inhibit it, then you know you have antimicrobial resistance. Okay, and this is a problem globally, leading to so many deaths. And it is stimulated as what is the word? It is estimated that in 2050, 10 million people will die a year from antimicrobial resistance. And why is it a concern? It is a concern. Why am I talking about this? Because antimicrobial resistance leads to treatment failure, leads to prolonged sickness, leads to death. It adds to the burden of hospital care. And then producing antibiotics is very expensive. We need so many years and a lot of money to produce antibiotics. And if we are not careful, we'll end up in the pre-antibiotic era. Now, let's look at the drivers of antimicrobial resistance. Now, this is a natural phenomenon that happens. And as far as we are taking drugs, antimicrobial resistance will be present. So some of the drivers is overprescribing. When our physicians, in the quest of trying to help someone, before anything is done, before Jack, you rule out malaria, the rest is antibiotic infection. So you go in and treat with antibiotics. And then patients not finishing their dose. And then the heavy use of these antibiotics in the agriculture industry, in the poultry industry, fishery, we pump them with a lot of antibiotics so that they will not die, so that they can sustain their markets. And these all lead to AMR because we end up taking residue from these products when we eat them. Poor infection prevention control, poor hand hygiene or sanitation, and very importantly, lack of rapid laboratory tests. So the fact that you are not running you're not running bacteriology in your lab means that it is going to have a lab to test. And so because of that, drugs will be given without prescription. All right. So with that said, I believe we are ready to go to the next level. In the meat itself, microbiology lab, you need to plan the scope. What lab do I want to set up? Do I want to set up a lab in a single hospital, like a single lab for just my hospital, a multi-center clinics? Do I want to set a standalone single lab, like not in the hospital, but attending to hospitals around? You have to plan all these things before. Look at the scope. And this will also you want to do, and the volume that you prepare, you perform. So you have to look at the tests. Okay, I want to start, but I just want to start with urine culture. And name it is stool culture. Then later I will set close to a maternity center, and I want to do wound culture where maybe there are surgical site infections that I want to culture. So you have to think of the tests that you want to perform. Now, media is expensive. Today, as of today, I asked of media in two places. One is selling it for $650, one is selling it for $1,300, based on the type of media anyway. So let's use live chem. Let's just be practical here. Looking at the scope, looking at the volume you want to prepare. So this cleared media It's 500 grams. It takes 4 years to expire, and it is 650 Ghana cedis. Now, if you want to prepare 1 liter of, the cleared, you get 40 plates. And for that, you have to weigh 36 grams of the powder. So for the whole 500 grams, you will get about 40 liters, giving you 560 plates. So let's go. Don't get lost. So 1 plate will give you 4 urine samples. 1 plate can culture 4 urine samples. That means the 560 plates will culture 2,240 urine samples. Now, these urine samples divided by 4 years, because the urine media will expire in 4 years. So 2,240 in 4 years means you need to get 560 cases per year. Dividing this per month, you will get 447 urine cases for a month. Coming down to a week, it means you need to get 12 urine samples a week. So if you sit down and you look at the lab you want to set, and you look at the people you are targeting, and you say, oh, okay, I think I can get 20 urine samples a week, then it means you make gains from your media. It will not go bad. You won't lose money. But if you can just run 5 urine cultures in a week, then you have to advise yourself. It's either you go in for small size media, which is not economical anyway, or you partner with another lab so that you can make gains from your media. So this is how you think of the volume and the test menu, the volume that you will run. So this is how you become practical, so that you can know whether you make gains or not. Now, you also look at the expectant growth over maybe 5, 10, 20 years. So you just want to set your lab in an estate, and people are now coming in the estate. Or you are setting your lab in, let's say, a place where people are migrating. They are leaving the place. The youth are leaving. So you have to look at all those things. Then you look at the funds, how much money you have. This will help you in planning your lab. Now, so what are the requirements? If you want to set up a lab, a bacteriology lab, you need to target a market. You need qualified personnel. You need a space. You need reagents, equipment, consumables. You need documentations, and you need to think about safety. Very paramount. Now, so people think microbiology doesn't sell, but in 2019 alone, 7.7 million deaths all over the world were found to be linked with bacterial infections. 7.7 million deaths. So it is the second leading cause of death globally. That's bacterial infections. Now, just think about your hospital where you work. When we talk about respiratory tract infections, you need a culture. Bloodstream infections, you need a culture. Gastrointestinal infections, you need a culture. Sexual transmitted infections, you need a culture. UTIs, you need a culture. Surgical site. So there is so much market for culture, for bacteriology tests. And so it is doable. And then there's also rapid advancement in technology. Every day things are changing. And so there's the market. And then research. We also how COVID changed, revolutionized everything globally. And we saw how, let's say, virologists or microbiologists became very important. Okay, when there are outbreaks, and surveillance also all fall in the market of the bacteriology lab. Now, for your qualified personnel, the person should have a diploma, a BSc, MSc, MLSD, or PhD in medical laboratory, particularly in bacteriology. The person should have sufficient skills to perform these bacteriological tests. Also, the person should be ready to learn. Maybe you finish a BSc or a diploma. Now we don't specialize. At first, we used to specialize. You finish a BSc, and then you should be ready to learn these skills, because they are a bit, students don't really like it because it's a bit abstract. Okay, now this qualified personnel should have a valid license with the Allied Health Professionals Council. And then the person should be a member of Gamls, of course, in good standing. All right. Now, when we talk about the space that you need, the space should be well zoned. And most of us, I believe, we might already have the space. We'll be working in hospitals. There'll be rooms allotted or allocated for bacteriology lab, or you may want to do extension for bacteriology lab. It should be a cement facility. It shouldn't be wooden or just PU, what's it called? TNG. No, it should be a cement block facility. And there should be well demarcated zones. We know the reception is separate from offices, from the itching area, from the testing area. It should be well zoned from where we store our things. We should just imagine having a bacteriology lab in a blood bank or around a blood bank, or sharing a room with blood banking and bacteriology. Just imagine. Blood bank goes into a patient, it should be sterile. Bacteriology, the processes, centrifugation, all those things can release things in the atmosphere, which may contaminate these blood products that we give to our clients. Or OGTT, where we dissolve glucose and load our client to test them. And you are preparing this in a bacteriology lab. It's a no-no. And also, let's say you have your main waste collection point of the lab close to or in a media room. And media is supposed to be a sterile thing for our processes. So you should demarcate your lab well. And all these things in mind to prevent contamination of people and of samples. Now, it should also be flexible, the flow of things, the arrangements, how you move in from one place to it should be free. The movement should be free. There should be adequate space for a person to work. The space should be well illuminated. A bacteriology lab should be well illuminated, because when you are reading plates, when you are reading your culture plates, you need lots of light to be able to see the microorganisms or the bacteria on the plates. The space should be well ventilated. Ideally, we should have local extraction fans and extraction fans above equipment, luminal flow cabinets, ideally, but it is not so. So you see, you start with what you have and make the best out of it. So you can just cope with your windows, just make sure that the room is well ventilated, well aerated, because most laboratory contaminants of the air, they include bacteria and fungi and the harmful chemicals. You enter a room, someone is doing ZS staining, carbofusion stain, pungent, fills the room, very, very bad for our health. You should open your windows so that these airs are chemical, are released or expelled into the environment. Now, your space should have escape routes, well demarcated, continuous, well labeled, unobstructed, very particular about that, unobstructed exit paths. Most of us, when you go to our labs now, our exit paths have been blocked. Our exit paths have been blocked with boxes and whatever. So this is what an ideal escape route should look like. No clutter around it. This is a no-no. This is a no-no. And I believe that when we go to work tomorrow and we check our exits, emergency exits, we'll see things. We have to clear them. All right. Now, the space should have adequate and constant supply of water, electricity, and should have gas. It should have pipes and cabinets that are well shouldered off. The benches that we use in the lab should be smooth, easily cleanable. It shouldn't absorb reagents or liquids that fall on them. And if ideal, it should have an edge so that spilled liquid will not run off onto the floor. The walls should be smooth, easy to wash. Ceiling as well, smooth, easy to wash. And then the floors as well should be smooth. The walls should not be absorbent. You shouldn't do wooden floor, wooden panel. No, you should use non-slip flooring. So our tiles, the non-slip ones, our smooth terrazzo but non-slip ones can all be used for laboratory floors. Now let's look at some of the equipment you will need. You need a distilled water plant. You need a chemical balance. Now, as you are looking at this, you are thinking of the cost. So you look at the water bath. Biosafety cabinets is, okay, you can start, as you are starting small, you can hold on with that. You can either use a gas stove or a magnetic stirrer or an electric heater for your heating. You need an incubator, hot air oven. You need a fridge. You need microscope, autoclave, a bacillerator or Bunsen burner. You need disk dispensers, computer. You need a vortex, plate rotor, plate counter, centrifuge, pH meter. This is just to mention a few. Just imagine the cost of these things on the market today. All right. You also need glassware. You need petri dishes. You can either use plastic or glass, test tubes, bottles, universal bottles for media preparation. You need slides. You need measuring cylinders. You need beakers. You need metal bowls, sample racks, autoclave tips, forceps, vernier calipers, swab stakes, sample containers, stationery, a whole lot of things is required. Then when it comes to reagents, media in the lab, cleared, blood agar base, McConkey, Muller-Hinton, the identification media like TSI, Indo, urea, all these things need to be acquired. Or them you might have already because of other processes, methylene blue Indian ink, lactophenol cotton glue, all these are. Then we need consumables. We need antibiotics. We have single disc antibiotics and multi-disc antibiotics. Ideally, we should use a single disc. That makes you a god or you're getting the multi-disc. All these. All right. Then, importantly, in the lab, say if it is not documented, it's not done. We need documentation, okay, and some administrative work. Extensive needs to be going on. Now, Facility Regulatory Agency, you need a license from them, and you need to boldly stick it in your lab. So if you don't have it already in your lab, you need to get this. These people will require that all your staff or your clients have the allied health license. You need to prepare standard operating procedures for the method that you use. Okay, so the methods that you use, you just don't start a microbiology lab. You need to look at the tests you do, and then you prepare your own SOPs. You can maybe take guidance from other sister labs, but you prepare your own SOPs suiting to you and your lab. But then it should always be approved by the Ghana Health Service, Ministry of Health, WHO, CDC, CLSI, or UCAST standards. You just don't do anything. It should conform to these standards that we have governing our profession. Then you need to get your quality management systems in place. You need to work on accreditation. I put it in blue because it is a whole big deal. Okay, you need to work on accreditation. And then you need to enroll in a national and international quality assurance program. Very important. This will tell you how you are faring as a lab. Okay, so you can know your standards, know where you need to improve and where you are doing well. You need to set your turnaround times, patient policies. All those things need to be prepared before you set your lab. Now, let us talk about safety and emergency equipment. So for safety in the lab, once the microbiology lab is going to be an add-on to already existing labs, I want to assume that we are familiar with most of these safety precautions. Every door, every room in your lab should have something like this. If you can see my cursor, every door in your lab should have something like this. I picked this from the internet, so it's not specific, but it should have the telephone numbers of your safety officer, emergency lines you need to call, maybe if there's a needle stick, those lines you have to call. You need to get the safety signs specific to that room, okay? So if you are going to a media room or a place where you have an incubator, you know that that place, there could be explosion of the autoclave. Hey, did I say incubator? So you are going to the autoclave room here. So there could be explosion of the autoclave. Or there could be hot, you can have burn injuries from the autoclave. So you need specific safety hazard signage or hazard signage attached to that door. So you should all have this in your labs, right? You should have the numbers to get in touch with, and this should be endorsed by the manager of the lab. All right. You should have your PPEs, the caps, the gloves, the nose mask. At first, it was only the lab and then health workers who used to pride ourselves with wearing nose masks. Now it's no more a pride. Everyone is wearing nose masks. So you should get your nose mask, your goggles, your first aid kits should be available in the lab. You should have fire extinguishers that are controlled or changed yearly. Change yearly, and then it is documented. You should have fire blankets. You should have a fire alarm call point. Some of these things can be very simple. In my lab, as big as my lab is, my fire extension, our fire call point is a bell. It's a bell hanging somewhere. So when there's fire, or when you are somewhere on the floor and you hear the bell ring, clink, 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 you know there's fire. You run to the assembly points. So like I said, you start small and then you make do with what you have. You should have a place where if someone needs to have a short sick rest or recovery rest, can use that place. You should get your spill kits also. Your spill kits, your eye wash, very important, because in bacteriology, a lot of chemicals and reagents, and even the powder we use can enter the eyes. So you need an eye wash. This is what most of the labs have. This one here, you push down and the water gushes out and wash. I didn't think most labs had it, but I saw it at Efia Cancer quite recently. And then you need to have a shower so that when there's an injury, a spillage, you can quickly have water to rinse off and dilute out whatever has contaminated your body. All right. Now, for our chemicals, acids, bases, we should have a safety cabinet for a storage cabinet for these solvents, these harsh solvents, and properly labeled and kept under lock and key with a key known by whoever is relevant to know it. Very important. We don't keep these harsh chemicals or solvents just every lab. For safety reasons, they should be kept in a safety cabinet. Then in microbiology lab, we use cylinder. Our source of fire is from the liquefied petroleum gas. Okay. So some people want to eliminate it, but you still have to use gas in some way. You can choose to use an electric stove, but when you are flaming your media, you need the open flame. Sometimes you can use the bacillinator or you can use the Benson burner. So we always need gas. And this gas, when it is loaded or when it is filled, should not be in the facility, should not be within the laboratory room. It should be outside the lab, outside the building, under a shaded environment, well ventilated, well labeled, secured from tilting or from falling, away from where people park their cars and where there's heavy human traffic. This is very paramount to prevent or to ensure safety. So when you are planning your lab, make sure that I will have a gas cylinder. This is where I want it to be. All these things should be considered or thought about. Now, as way of emergency, you should have your emergency lighting. You should have your well demarcated, unobscured fire exits or emergency exits. We have seen this already. Now, we have to think about waste management when we want to set up a lab, bacteriology lab, because the type of waste we generate is a bit different from what other, maybe hematology, chemical, pathology, or immunology. Some of these things you add reagents to them, and then they may kill any possible pathogen in there. But for the bacteriology lab, we are growing live bacteria. We are growing live bacteria or live fungi on a plate. So we should really segregate our media according to the hospital's protocol. If the hospital's protocol is not ideal or is not set up to meet the microbiology needs, we should design protocols to absorb this add-on. So the waste we produce here should be segregated. Media should be, used media should be properly treated, autoclaved, in a dirty autoclave before they are discarded. Samples that we generate, the liquid waste that we generate, most of them end up straight in our gutters, in the hospital waste, sewage waste, and they end up in our water bodies. So there are ways of treating these liquid waste: oxidation, membrane filtration, and UV treatments. But personally, I haven't seen any hospital that does extensive liquid waste treatments. I stand to be corrected. I think in Kolebu, I know about the Public Health and Reference Lab. Far back, I knew that they had a tank that when their waste goes in, they treat it before it ends up in the main sewage. I don't know if it is still working, but we can do the little we can in our own corner. So for our liquid waste, instead of just pouring them down the sink or down the drain, we can pour them in disinfectants, Vercon, bleach, whatever be the case, whatever can rid of most of the pathogens, and then before we discard them. But also there's a two-way, because it's not only our water bodies that are contaminated with bacteria or pathogens. They can also be contaminated with residual materials from these chemicals we use in the lab. So it's a two-way thing. So when you are going to set up your bacteriology lab, you think of waste management. I know most hospitals, they pick their waste, Zoom Lion picks their waste, and they charge them based on the type of waste they produce. And one very good friend of mine, I think she's on the field, she told me that in her hospital, if Zoom Lion picks a waste, and then let's say it is supposed to be general purpose waste, and finds just one glove in that general purpose waste, he would the Zoom Lion will charge them as they are charging for infectious waste. So there's a need to properly segregate our waste. Now let's look at this recent study conducted in Kolebu, where wastewater from the maternity and children's block were collected and cultured. They found E. coli, Klebsiella pneumoniae, Citrobacter furendi, a lot, Pseudomonas species were found. And the most important and the most alarming thing is that they found multi-drug resistance pathogens in these the woman sells the wachi. But this waste contains not only bacteria, but bacteria with multi-drug resistance. Those bacteria that you cannot treat them, you have to buy, may not be able to treat them. So this bacteria is going out of the hospital, passing behind the woman who sells the wache. She'll be selling the wache and then the wache bar or something. I'm just trying to, the wache leaves something, some way, somehow. This water ends up contaminating the food, the spoon, the leaf, whatever. We can end up spreading. Amongst them were also ESBLs. Maybe new to some of you, but ESBLs were also found in some large. The cost was very, very high. This is not to scare those of us who want to adapt bacteriology to our itinerary of tests, but then for you to know that it is very expensive to set up. The quotations they gave me in dollars, and a few equipment is costing about 40 to 50,000 USD. It was very scary. So this is not to discourage us, but then you can start small and then move on. Okay, or we can also seek for governmental sponsorship. We can also partner with some of these suppliers. Some of them want to just come and dump the equipment there for you to buy the reagents. Once you have the markets, they will be able to do that. Or we partner with sister labs. So, okay, we want to set up a lab. We'll buy clay together and we'll share it. We'll buy this reagent, we'll share it so that it is doable. It is expensive, but it is doable. All right. So a few challenges when it comes to setting up a bacteriology lab or, yeah, having bacteriology laboratory. The costs, of course, a cost involved. And then sometimes stringent international policies. Sometimes you want to bring in something, there are some policies, there are caveats, holding something back. For some time, for over a year, we were not running black water because we just couldn't find the bottles. You have to go and pass through Dubai some way. You want to get antibiotic disc, you have to, it's a whole lot. There are so many policies institutionally that can make things difficult. Let's say, for instance, during the COVID, for my lab, our external quality assurance was coming from Germany. Anytime it comes, it was coming from somebody. Anytime it comes, it hits another country, the country puts some policy and then it goes back. It comes to that country before it transfers to Ghana. It goes back. Several times our QA sample was going back because of some policy. So later something was raised. So those are some of the challenges that we have. And then the rapidly evolving technologies. You go and buy this equipment, you go and buy this reagent you are using, and then suddenly they say, oh, it's obsolete. Now there's a new thing, there's an in thing. So those are some of the challenges that we face, just to mention a few. So in closing, I want to say that the lack or availability of functional, not just bacteriology, functional bacteriology labs, it supports the inappropriate use of antibiotics and it affects the patient overall. So your lab not running bacteriology, my lab not running bacteriology, we collectively contribute to antimicrobial resistance because your doctor will prescribe without the tests. Maybe what they can better do is to take it outside the lab and then run it. But then most often they'll prescribe without the test because you don't run it. So we need to get involved. We need to get on board. It is doable. And then I also call via Gamls through Ghana Health Service, Ministry of Health, all the important stakeholders to support the agenda of bridging the gap between the number of laboratories in the country, and the number of laboratories doing bacteriology tests. Yeah. Thank you very much. And then if there are any questions, I will attempt to answer them.
Thank you very much, Dr. Okai, for this brilliant presentation. I think the essence of this program is that Gamls as a professional body has seen the need for us to close the gap as professionals and as managers of facility. That is why this thing has been put up. So Gamls is already on board. So at this point, before we start the questioning session, our president is here. I'll give him the first opportunity, and then we can open the doors for questions. So we'll take the questions in 5 batches. If you want to ask questions, kindly raise your hand and we'll call you. We also want to tell you that we are advancing in technology. So we are broadcasting this on Gamls TV on YouTube. Those of you who cannot join us via Zoom can have access to the platform for each day's presentation on Gamls TV, and want you to subscribe to this channel. It is becoming a TV for the professional body to keep records and also broadcast what we do as a professional body. Thank you very much. President, are you here?
Thank you very much, GS. And I want to thank our mom, Esther, for such a wonderful delivery. I know very well that from all that she has given us, a lot of us who hitherto have no interest in setting up or have not been given the needed impetus to put up a bacteriology lab will certainly do that. Ma'am, we said thank you so much. And we are hoping that we'll have another opportunity for you to reiterate all this so that together we can be able to build the systems as expected for all of us. Thank you. And for members who are on the platform, I say a very big thank you. Please join the Gamls TV once in a while so that we can also be able to establish the system. I want to thank the organizers, all those behind the scene, GS and the team members for such a wonderful work, not forgetting PRO, and then our training coordinator, our pastor, Dr. Aiku. Thank you very much.
Thank you very much, President. So this program is supported technically by our IT team, the PR team led by Dr. Dennis Edujesi, and all the coordination is done by our training coordinator, Reverend Dr. Aiku. We say a big thank you to all those who, and also the staff of the Secretariat for their support. So at this point, we want to have the questions. Obed, kindly ask your question, please.
Thank you very much. In fact, great presentation by Dr. Esther Okai. I've really learned a lot and also gotten a lot. But I'm also asking my question based on my experience at Sunyani Teaching Hospital, where we do extensive microbiology and then bacteriology. But then my question to Doc is that most often when we talk about bacteriology, I think one of the reasons why we fail to get funds and enough support is that we limit microbiology to only bacteriology. So you see, we'll start with maybe AMR, antimicrobials, but then when we are really talking about it, our focus will be on antibiotics. Then we leave the other antimicrobials like the antivirals, antifungals. So you see facilities recently there was antimicrobial resistance, and then the focus was on antibiotic. So maybe if Ghana as a country can also say that we are also targeting the antivirals, the antifungals, the antiparasitics, which all fall under the microbiology, I believe we'll be able to do a lot. So I think the focus has already been bacteriology, but then we are looking at microbiology, which is very broad. And I believe when we do that, we can have donors sponsoring the other sectors, especially the antiviral research into antiviral, and would like to support in those areas. So thank you. That's one of my questions. Thank you. But
Thank you.
unless Dr. Okan has a different view, why is always bacteriology?
I think she will respond to you appropriately. Maswatete. Then
Good evening. Good evening. Please, I'm very grateful for the presentation made by Sister Esther. I would like to ask, how will the slides be made available to us with the participants so that we can later reference or learn from it? Thank you.
All right, thank you. Isaac, can you come in? We are on a professional platform and we are advised to mute as well as put off our videos. It will be, we may expose our privacy if we don't comply. So let us comply, please. Can you answer a question?
Dr. Kwashi, can I go ahead and answer the first three?
You do.
All right. Okay, thank you very much for your, I think it's more of a submission than a question. So, in fact, when we talk about Ghana and diseases, there are some major stakeholders, HIV, malaria, before we come to bacterial infections. So, for many years, HIV has been drumming, prevalence has been drumming, malaria and the prevalence have been drumming. Bacterial infections, in fact, to get, let's say if you want to Google UTI prevalence in Ghana, you will never get it. You only get maybe UTI prevalence in maybe pregnant women, from surgical, from surgery, from a certain ward. So I think it's the exposure or education when it comes to the resistance in parasitic or viral or fungal infections. Because already malaria is well known, or viral infections are well known through HIV, through malaria. Bacterial infection, in fact, AMR just started coming up. And then as of fungal, it's sad, but I'm sure it will pick up as time goes on. So I think it's up in those areas. And I think together we can all rally behind us to really shine the light on the other fields in. And antimicrobial resistance. In fact, when you say antimicrobial or I think it should be clear here that you can have resistance in viral, parasitic, fungal, and bacterial infections. And they can all be targeted at different planes. Get the slides through the recordings, or whichever way Dr. Kwashi will permit it to go through.
Okay, thank you very much. I think there's a contribution or a question from...
I think those were the questions I got.
All right. If we overlook or we forget about your question, please feel free and remind us. I've seen Senior Michael Bafu-Asari. Are you here?
Yes, Doc.
Kindly ask your question and contribute.
Okay, thank you very much. I think that was a very wonderful presentation from Dr. Okan. And I would want to admonish us to really look into the idea, because the gaps that she has actually presented are huge. And it's something that we can really work around. I'll start from the point of contribution of the gentleman from the Sunyane Regional Hospital. I think when it comes to microbial infections, currently AMR is the in thing. So somebody will say that is the ongoing pandemic, if you like. So at the end of the day, we have to use the approach of the low-hanging fruits, because that's the area where we are being hit the most. Because when it comes to things like the parasites and all that, we've really been able to do a lot. But unfortunately, for areas like virology and all that, sometimes it's quite difficult in terms of the amount of money that is required. Because myself and Dr. Okan were looking at some of the figures earlier before her presentation, and we could see that even for bacteriology was quite difficult. So I think we have to really look at what it's doable and do it the easiest way. And I will use one facility as an example. Actually, the past 2 years, they wanted to actually set up a bacteriology lab. They didn't make any consultation. So before I realized, I had actually gone to purchase one of the semi-auto analyzers. I don't know how many of us are familiar with it, the microscan. And the microscan alone could cost them about 150,000 Ghana cedis as at then. So they actually contracted me to set them up. When I went there, with the exception of that particular equipment, there was nothing like incubator, fridges, even the cheapest that we could buy. So I actually advised the CEO in charge that, there are other methods which are the first principle that can actually be used. So why not go that way? So we did our analysis, and then we actually showed them all that they need to buy. And surprisingly, the price was even about, let's say, 25% of the cost of that particular equipment that they purchased initially. So once we are able to set them up, we started to do data analysis. So every month, we put the figures that they get in terms of the case numbers translating into their income. And it will shock you that within a matter of 6 months, they were actually able to hit more than 150,000 Ghana cedis. So definitely, they've been able to even pay off the equipment that they are not even using. But then, let's look at a situation where we're supposed to use the fully auto analyzer, where we would have to go and buy all these things in addition. So if you go and buy all these things, and at the end of the day, we are unable to meet the target in terms of the case numbers and all that, finally, the lab will run at a loss, and they may try to even fold up. So these are some of the reasons why you need to do your feasibility studies and see the case count. Because if you talk about virology, for instance, with the exception of COVID coming in, how many viral assays are we even testing in our environment here? It's not also cost effective. So you look at all those dynamics before you actually set up. So I think Esther has really done well by doing justice. And then if you need further consultation, I think she's free. She can give all the knowledge that you want, and there are other senior members that can also contribute. And together, we can bridge that serious gap that she has actually identified. Thank you very much, Dr. Solomon.
Thank you very much. I knew you were not coming to ask a question. You were coming to contribute because of your background. And Michael is one of the astute medical microbiologists and currently pursuing his PhD in medical microbiology in the University of Ghana. I earlier saw the hands of MLS Bright Robe. Are you still around? Maswa, kindly ask your question.
Please, I earlier on asked that I would like the slides to be put on the WhatsApp pages. The advertisement was made for the Zoom meeting.
All right,
Thank you.
we'll do our best to share with you. I think there are some comments. There are people here with entrepreneurial eyes. Somebody saying that I can see entrepreneurial opportunities in microbiology that can help train interested medical laboratory professionals in how to manufacture antibiotics. Okay, it's a question. Can you help train interested medical laboratory professional in how to manufacture antibiotic sensitivity discs, Petri dishes, and loops? Okay, we'll answer that question. There's another comment from MLS Dr. Asilevi. It says that the methods to find out names of infectious organisms cost a lot. When it's confirmed bacteria, when it is confirmed bacteria, I think the only sensitive pattern is needed in therapeutic. Very clearly. And yes, the question is, do we have some expertise in manufacturing our antibiotics locally? And can you also tell us about some of the pertinent risks associated with the practice of bacteriology?
Okay, all right. Thank you very much. I'll start with the risk associated with bacteriology. There are a lot of risks that, of course, like I discussed, when you are thinking safety, you know that something is in there to come and bite you. So a lot of risks practicing microbiology. You can have exposure to pathogens, infections. You can have exposure to chemicals that can cause injury. You can even be inhaling the powder from culture media for so many years, and then you end up having some lung infections. So there are a lot of risks involved there. Also, I heard one question that said that the costs in identifying bacteria is very expensive. So once you know it's bacteria, I'll just do sensitivity. I am very bold to say it is a big no and a wrong practice, because we are building data. We are building data, national data, international data. So there are lots of systems that at the end of the day, you churn in your results. So you say, oh, this year I had 200 E. coli, and out of them, this number are showing a certain trend of resistance. So if you go in ahead and just do your sensitivity without identification, how can you come out with meaningful data to inform treatment? Some of these empiric treatments we give in the hospitals, it's as a result of long-term data that has been accrued and analyzed. So you can vehemently start an empiric treatment of a certain GNR with a certain antibiotic because data proves that it works. So please, if in your lab, you just identify, you just do culture, what is it called? You do sensitivity without identifying the type of pathogen, it's a big no. Please, I think you should get at least the minimum manual way of bacterial identification to help, so that you can even come out with publications that, oh, in my hospital, this is the most prevalent UTI pathogen that we have from maybe children, from pregnant women, from this number of people. So please, let's try and identify the bacteria. Now about the entrepreneurship, I think everything is doable. All we need is the specifications. Let's take for the Petri dishes. We have a lot of companies on the market that are producing plastic, various forms of plastic things, and they can equally produce these Petri dishes for us. The loops can equally be prepared or produced in the country. My little challenge is with the antibiotics production. It is very possible. So when it comes to controls, you are setting controls for newly manufactured antibiotics. You need a large range, a large pool of bacteria to be able to get some of these ingredients from them. So let's say you have your liquid medium and then you put, let's say, Bacillus cereus in it because you want this toxin from the Bacillus cereus, which can help in treating a certain infection. That system of getting that large dose, it is doable, but it needs a lot of commitment, like we have already established. A lot of policies have to be put in place to control, to check it so that we don't come out with another menace. So whatever we have said here is doable. We need commitment, we need funds, and we need expertise in that area to do that. I think it's doable. In my MPhil, I had a colleague, Lord Bassin, I think, yeah, Lord Bassin, Dr. Lord Bassin. And as at then, he was producing some, cassettes for testing some of these infections. He came out, I think he later got some, it was doing well, but there was some resistance somewhere, but it is to be expected. Ghanaians, we hardly like what is from our own. So it is doable, and I think once, thank you.
Thank you very much. There is another question from a participant asking whether there is currently a national EQA program you know of that you can share with us.
I think I lost you there. Can you come back again?
The participant want to find out whether there is a national EQA program in bacteriology currently in Ghana.
In Ghana, I think I have a few colleagues who have something running. I think it's in good time. I know a few colleagues who are running something.
So, to the best of knowledge,
Dr. Kwashi?
But then when it comes to
Yeah, I was saying that, yeah, we have some that I'm aware of. We have like the Kintampo Research Center.
internal.
Yes, external Kintampo. Yeah, they do some slides usually for these CSM slides where they send to microbacteriology facilities to stain and then view and then comment. Then after they are also done, they also assess and then do that. Then external from outside country, we have the UK NICAS. We also bring some EQA slides and then cultures that we grow.
All right, thank you very much for the information. To just add up to EQA provision is something on its own governed by or where the providers have to meet certain minimum requirements. What we currently have in Ghana are inter-laboratory comparison programs where you can send samples to other labs for them to, and you compare results. We don't have a running national EQA system that meets international standard ISO 17043. We don't have it now. We are aware that the African CDC, the Ghana Health Service, and the National Public Health and Reference Lab are doing some work, including ASLM. There are some work ongoing to establish some platform for Africa and for that matter, Ghana. So currently, for EQA, national EQA system, we don't have a certified EQA system. Thank you very much. And we are grateful, Obed, for the information. Obed, do you have any question?
Yes, yes, I have a question. One thing about microbiology is that it's easy mostly to, sometimes establishing it is okay, though they are costly and other things, but then sustainability becomes a problem. Sometimes you see you have to shut down for a very long time due to procurement challenges. So I was thinking maybe this to Gamls, Is there a way whereby the laboratory can have our own account, whereby sometimes you make the request and then you have other people going to procure? Sometimes even the things they will bring. I quite remember we needed single disc antibiotics. Then they will go and bring multi-disc antibiotics. Using them for they have their disadvantages. So if maybe in general the GAMS can push for a way in which the laboratory can have our own accounts, whereby procuring certain things for the lab or will not be that difficult. Otherwise, you see that sustaining microbiology usually becomes a problem due to procurement issues.
All right, so before the presenter comes in, your question borders both on advocacy and also quality management system. As a laboratory, we are supposed to develop a quality management system that ensures that whatever that we request for purchase meets minimum specifications. So you send items to be bought based on specification. You should have a system to ensure that there's evaluation of the process. And I know the procurement, there's a board or a committee in the hospitals that ensures that, okay, all those who have tended to supply the item meet certain requirements. And when the items are brought, samples are brought to the hospital or for the lab to ensure that they meet these requirements. If we don't have this system, let's put up the documents or the procedures for this and ensure that management approves it and management is committed to the implementation of this. If you have this system in your hospital and they buy something for you that doesn't meet the requirement, and reject it confidently, because that is the procedure of the hospital or the lab you are working in. But if we do not have a system like this, whatever comes in, we'll accept it. So let's ensure that we build a system and enforce the system. If we do that 1 or 2 times, management will know that we are serious. We have a system that works, and they will not just dump anything on us. The accounts. I think we have advocated for this account forcefully over the period. Even though it has not been successfully, we see it as an important thing to still advocate about. So we are still open for suggestions. As leaders, we are open. You can put your concept paper, how you think it can be done sustainably, to us through info@gams.org, and we'll take it up. I think I saw Michael again.
Yeah, doctor.
Yes, kindly contribute before the presenter comes in.
Okay. Yeah, thank you. Yeah, I actually appreciate the concerns of our brother. And it's not easy running the microbiology, because at the end of the day, most of these suppliers, because of the knowledge gap that exists, they don't actually also import our products in store. So most of the time, some of the items, when you sit down and then you have stock out, it will take you a long time before they can actually import it for you, which is also one key challenge that we should be looking at. So we should be able to also forecast and then tell by the consumption pattern that, oh, maybe these are the minimum stock levels that we need to have at any point in time. And then I think if we do that, our suppliers will be able to meet our needs from time to time. And then secondly, in the absence of the pegging, or if you like, the shielding of the account for us, I think there's also a way that we can also prove to management. I mean, management is all about the money. So at the end of the day, how are we able to? We need to be able to also be interested in telling them how much we are generating with the little that they give us. And I'll still use one laboratory, for example. When they actually set up, I also instructed the MLS that every month he should just give me an Excel sheet of all the tests that he has done. And then I coded it for him. So what happened was that if this month, let's say by the end of June, he has done urine CS 25, he has done blood CS 10, he puts all of them together. And then by the click of a button, he knows exactly how much bacteriology alone has made. And over time, when the CEO, he makes any request to the CEO doesn't hesitate because he knows that with the little that he's putting in, he's making more than even sometimes 100, 150% of what they invest at every point in time. So we should also be proactive. When we get the inputs, let's show them the figures. And when we give them these facts, I'm sure sometimes when you push them, they will be forced to give you what you need to work. We should be interested in the money, actually. Like somebody was saying, the entrepreneurship is all about the money at the end of the day. So show them how much you are generating, and then you make a case. And at some point in time, these CEOs and medical directors, I'm sure they will throw a line. Thank you.
Thank you very much. Dr. Okai, any adapts? Dr. Okai, can you hear us? All right.
I can hear you. I'm back. Thank you. I think I went off a bit.
You could as well contribute to the questions.
Okay. So I'm just going through the chats and I see Evans asking whether we can set a lab in all centers. No. That answer is no. Because the types of health conditions maybe a CHIPS compound will attend to may not merit a microbiology lab, looking at the cost involved. So we have rural districts, regional. So it's not all labs, all health centers that are supposed to set up a culture testing facility. I see from Bright Roby that his concern is that some of these private labs do not have even a designated place to run cultures, but they are working on these samples. And I think aside Gamls coming in, I think allied health professionals council should intensify monitoring or inspection of some of these private facilities and even governmental facilities as well to see that the right thing is being done there. I don't know how Gamls can come in with assisting this, but I know the Allied Health Council can do that. I'm also looking at, I think we've done this. Yeah. I think I've spoken about what I've seen. I don't know if there's any other questions that will come up.
Thank you very much. There's a question here. Can I sell medical laboratory equipment if I have a business certificate, or do I need a specific license before I can operate? I think you are qualified to sell medical laboratory as well as hospital equipment if you properly register your company. And the fact that you are a medical laboratory professional gives you the advantage to properly advertise and sell the best equipment to our colleagues and ourselves. So I think we are not only interested in testing, we are also interested in ourselves going into business. So kindly go ahead. There are people already in this business. So
yes,
sir.
Yes. But in addition, he should also check what are the objectives of his business. Okay, so when he was registering, he would have been asked the scope of the business he wants to run. If laboratory equipment or hospital equipment are not part of it, he can go and update his registration and then continue with his business. That's what I want to add.
Thank you, President. I think our president is a businessman. You can contact him behind the scenes to guide you. He's already in the lab entrepreneurship business. Philip, I think Philip will be the last person to ask the questions. Then we'll have final comments from the presenter. Okay, we have Dr. Usher. Dr. Usher will come in first, then Philip will continue. Then we'll have the last comment from the presenter. Then our training coordinator will come in. If the PRO is online, after the training coordinator, he will come in. Thank you. Dr. Francis Osha.
Okay, thank you very much, Doctor, for giving me the opportunity. And congratulations, Dr. Pokan, for the presentation. Ayuko. So, as much as I agree with you that it's not possible to have microbiology services across the country or in all the laboratories, I also feel that there are some basic related tests in bacteriology that can be done at the very lowest level. So, for example, if you have, I've not done microbiology for a very long time, long time, but at least I remember some one or two things. So if you have a stain, like, is it gram stain, right? If you have a gram stain and somebody comes to the lower facility, the health center or the chief center, and then there's a urethral discharge, at least by performing a smear and doing gram stain, you could help save somebody's life. You know, if somebody have a sore, you could take a swab and even do just simple gram, and before you realize, somebody's life will be saved. This is what, when we do our services, will be needed in some of these places, and it will cascade upwards. So that's my comment. Let's try and make ourselves relevant at the lowest level by doing some of these basic laboratory investigations that may not cost much. As far as I'm concerned, I don't think gram stain after you prepare the reagent will expire in the shortest time. So in the short to medium-term plan, let us begin something gradual, and maybe as time goes on, those lower facilities could even be doing some serological tests that are related to bacteriology, and gradually we'll be building ourselves at the bottom there. Thank you very much, and over.
Yes, good evening to all. My question is that our union, I'm saying this thing because the presentation is about establishment of a microbiology lab. So I want to know, is there any sector or any mechanism in place to raise the appetite of anybody who want to establish microbiology lab? Because it's going to serve as an employment for most. So I'm asking if our union or the Gamls have some mechanism in place or sector so that anybody who wants to can go there so that you get an assistant in order to establish a microbiology lab.
Thank you very much. This is an important question. Because of the importance we have for that question, I will draw the president's attention to respond to you. President, kindly respond to that question.
Yeah, so there has been some work already ongoing, which we term as laboratory across the country. The essence of the laboratory across the country is to provide needed resources for as many as possible our members. It is hinged on the idea of the community pharmacists. Okay, so we believe that as medical laboratory scientists all across the country, there are places where we will need to establish the standard of the laboratory. And so this is going to be something that we are going to present for all our members across, irrespective of wherever you are. Once you are able to provide us with the needed interests and the fact that you are ready to join the program of labs across the country, we should be able to join hands together so that we can take our space. The idea is basically just as you know, when you take the pharmacist, for example, look at all the chain of the marketing. It's taken by pharmacists from the, what do you call it? From the pharmacy shops to the community pharmacy for even manufacturing. Every aspect of it is pharmacists. So the same way we want to encourage our members so that the space of medical laboratory science can be taken by us. Currently, as you just one facility, okay, others are trying their best, but then you can only get one bacteriological lab, which is the regional hospital. Others are trying, but they are not able to meet the standard. So how can we have just one bacteriological lab in this whole region? Can we improve upon it? If we are not able to help, can we get one other facility, either private or public, to join the process? So these are ways we are trying as much as possible to do. At the same time, too, we are also trying to work with the AMR team, the antimicrobial resistance team, Prof. Opintan and the group, so that we can be able to establish one standard across the country. Okay, is the CHAC facilities, so that every laboratory that is running bacteriology runs the bacteriology according to the standard that we have all decided to accept. So these are programs which are coming on board, and we are hoping that we will have Doc coming online during Congress to come and reiterate it, whilst we also get the standard also being brought together so that we can all accept and be sure that we are able to do a lot. But there's much coming on board to help members in the private sector, in the government sector, who want to establish a bacteriological lab to be able to do so with support from our partners. Thank you very much.
Thank you very much, President. I will invite Dr. Francis Osha to, even though we are at the tail end of this program, we'll have a presentation of code of ethics and conduct. There's a question here that, or a comment that I think Dr. Osha can help us with. It says that, but for your point of refusal or rejection of supply, when one rejects some items, this management will go to our top leaders and tell them your boys are sabotaging him or her. Our leaders will not even call you for your side of the issue, rather acting in favor of management. Dr. Francis Osha, these are issues of professional ethical dilemma. When this happens, what do you do?
Okay. Thank you very much, GS. So let me say that we are all learning and we are continuously learning. There are some practices that some people have been, doing their profession. That's bringing the name of the profession to disrepute. And the example is what you just said, the example that the questioner gave. It is highly unprofessional for anybody to behave like that. If there's any supply or any product that is not good for you to use to work and you have to reject it, please reject it. And let me also remind members that there are code of ethics of the profession, and there's also disciplinary committee for the profession. And therefore, if anybody commit any professional misconduct, you can bring it to the attention of the disciplinary committee to investigate and take action. No food soldier, no member of the profession should be afraid about anybody. We are all working in the interest of the patient and the profession, and so nobody can abuse or nobody can create any form of confusion in the profession by reporting other members to any other person. We have come this far and we have the capacity of fighting our own battles and solving our own issues. If a member has done anything that you think is not good, bring it to our attention, and then we address it peacefully, and then we continue with our work. Thank you very much.
Thank you very much. As I already said, getting to the tail end of this program, we'll have days for Dr. Francis Usher to talk to us about professional ethics and code of conduct and how we can handle some of these things. So let's prepare ourselves for that. Dr. Okai, can we have your closing remarks or your final words as we expect you for another presentation tomorrow?
I want to say a big thank you once again to the Gamls executives, National and Greater Accra, for having me. And I thank the participants as well for their great contributions and questions, and all those who assisted in the back door for this presentation to be a success. I look forward to see you tomorrow for us to continue to learn, relearn, and unlearn. Thank you very much.
Thank you very much. Dr. Aiku.
Hello, GS.
PRO.
Yeah, before Dr. Aiku comes, I want to admonish members to remember and subscribe to the Gamls TV account so that they will get notification, and we will keep our own account running. That's what I wanted to say. So as many as are available, let's propagate. Click on the link and just subscribe to the page. Thank you.
Thank you very much. I think our PRO has been one of the visionary PROs. I think the only PRO we have so far, and has been very supportive behind the scenes. Most of the things you see us do, it sits behind the scenes and support us very, very well. We are grateful, PRO. Dr. Aiku, we want to know what's the plan for tomorrow and the subsequent days.
Yes, thank you very much. Dr. Esther, okay, thank you. We are looking forward for more insightful presentations continuing from tomorrow to Friday. I would like to tell members that we have a lot of people who have registered, but it's not everybody who is in attendance. Those who have attended today, unfortunately, there are some from the beginning you were to relabel the names you are using. Some are using your phone names. Some are using your names, Lydia, Zion. You can't use it to compute attendance. So please, from tomorrow, we'll give that reminder when we start. You should input your full name as you registered with, as is with the council, so that we can use that to compute the attendance sheet. The fact that you are registered to attend the program doesn't mean automatically your name will be submitted to the council without you taking part. So please, let's take note, as well as inform our staff, our colleagues, that it is a learning process. At the end of the program, we should have learned something, not just for CPD points. That's why we are organizing this. So tomorrow, we'll start at 5 p.m. as we did today. We put the time at 5 p.m. because we are expecting that if you are on morning shift, by 5 p.m. you should be home. The afternoon staff could join at work, and then the night staff could also do before going to work. So we want everybody on board. So let's take note of these points, and tomorrow we'll continue. If we tabulate the names, it's a 10-day program, and you only attend one day, it doesn't befit you getting you're on the attendant list. So please, we are doing this to be able to earn something. Microbiology, a lot of facilities do not do. At least at the polyclinic level, you should be able to have microbiology in all polyclinics. So it's the basis that we're getting to start something with. We have the technical knowledge from schools, but it's not as simple as just starting it. That's why we are having the basis. It's a refresher. So please, tomorrow we'll start. We'll continue with today's setup. And hopefully by Friday, you come along with the facilitator that you are at the point of preparing, or you are convinced to convince your management to come on board. Thank you. Yes.
Thank you very much, PRO, for, sorry, National Training Coordinator, for your comments. And I think we should take his admonition very seriously. We are not just giving out points. We want people to participate. That is why through the PR of our organization, we have been able to create a channel for you to go and review the presentation and learn something. So we are not just giving out points. The avenues are there. The recordings are on YouTube. Please go, watch, subscribe, put a comment there. Let us know that you are a participant in this program, not just that you have registered whilst we were collecting data. Please go back and register or get your attendance for each day. Thank you very much. Before the president comes in, tomorrow, Gamls, in collaboration with the Society of Medical Laboratory Managers Ghana, African Society for Laboratory Medicine, and LabVine, we bring to you Laboratory Managers Seasonal School 2024. It's a free program. What you just have to do is to register, and a link will be sent to your email. And let's participate in this. When you look at the program outline, there are interesting topics for us to learn from and learn from others in other jurisdictions. So let's register and participate in that program before we come back here at 5 tomorrow. So that program starts tomorrow, 1 p.m. to 4 p.m. and continues the next day, 1 p.m. to 4 p.m. Thank you very much. President, any final comments? If the Vice President is here, the Financial Secretary, you can give your comments. Vice President, are you here?
Good evening.
All right, President, your final comments. All right, so on behalf of the National Executive Council, we say a big thank you for your participation, and we will see you tomorrow. And we say a big thank you to Dr. Okain for your time spent with us. There's a hand raised, Kalazi A12. Do you have a comment or question for us? And we want to know who you are. All right, so on that
Yes,
side,
I do have a question. Hello. Hello.
okay.
Yes, I do have a question. Yes. Thank you guys for a very educative and informative program. I wanted to know, how are you able to monitor those who took part or participated during the program from the beginning to the end, in order to perhaps if they have any questions after the program, they can follow up, and who should they meet or who should they contact for that purpose?
All right, so if you realize on our pages, we have created a link to take attendance for each session. So there's a link on our platforms to monitor attendance today. If you partook in the presentations, kindly fill the form for us to know that you really partook in the program. And if you want to get in contact with the presenter on Friday or within the week, we'll share her email address for you to get in contact with her. And so let's go back, fill the form if you really partook in the program or have watched us on YouTube. Thank you very much. Please, have I answered you? And may I also know who asked the question?
Yes, please. I'm Thomas Ayi from the Bank Hospital.
All right. Thank you very much, Thomas.
Thank you too. Thank you.
On that Thomas note, we say a big thank you and see you tomorrow. Bye for now.
Bye.
Bye. Solo no prayers.
Thanks a lot.
Subscribe and share the link.
Pray for us.
Bye. Thanks a lot.
Bye.
Subscribe and share the link.
Bye.
See you tomorrow.
Bye bye, baby.
Bye.
Bye-bye.
Bye. Come here.
Even though you were here with us, go to YouTube, subscribe to Gamls TV. Let's make it fun. Every one of us subscribe to Gamls TV. Thank you.
Okay.
Ophelia Kote, I miss you.